Good evening. I'd like to welcome you. Let me get the microphone calibrated. Is that about right there? Too loud? About right? Okay. Welcome to the third in our series of the Stewart and Marianne Reuter Medical Humanities and Ethics Grand Rounds. Tonight, we have the great pleasure of hearing from Dr. Michael Paasche-Orlow, who will speak about how health literacy can improve outcomes and ease disparities. But first, I would like to recognize the generosity of Dr. Stewart Reuter and his lovely wife, Marianne. Their endowment made, among many, many other things, this Medical Humanities and Ethics Grand Round series possible. Now, Dr. Reuter, for those of you who did not have the pleasure of knowing him, was a Renaissance man and a passionate humanist who served for many years as the chair of our own Department of Radiology here at UTHSC. What you may not have known is, besides being a world-renowned expert in angiography, he was also a lawyer, a teacher and a mentor, an artist, a philanthropist, and of course a leader and a visionary. Now, Mrs. Reuter, truly an amazing woman, is an accomplished artist and a philanthropist, and she and Dr. Reuter were full partners in their exceptional, very exceptional life accomplishments. And they strongly supported each other's efforts and passions and achievements. Now, Ms. Reuter received her bachelor's in art history from the University of Michigan, and she also received advanced degrees in philosophy and higher education, also from the University of Michigan. She also received an advanced degree in museum science from the John F. Kennedy University. Now, she has worked as a community volunteer in the arts and humanities since 1980, and she currently serves on the board of the Center for Contemporary Art in Santa Fe, where she currently resides. She is a life member of the advisory board of the College of Liberal and Fine Arts here at UTSA. We are most privileged to have her here tonight, and it's my great pleasure to introduce you. Ms. Reuter?
Thank you, Adam, for that wonderful thoughts about my husband and very nice introduction. Thank you so much. I'm very happy to be here, and I'm very excited about Dr. Ratner's series, Grand Rounds for the Medical Humanities. I thought tonight that I would just tell you very briefly why Stewart and I felt it was so important to support the medical humanities and ethics. We felt that in the education of future physicians and healthcare workers, there is a lot of science, and we always wanted life to have a taste of the humanities. We felt it was very important to humanize efforts, so we would all become human beings sensitive to each other. In order to become, what shall I say, a well-rounded person, a person who can communicate beautifully, we felt that by studying the humanities and the ethics, by being exposed to knowledge through philosophy, by learning to read the languages in the arts. The arts are made of symbols, there's a lot of myth, and all this is kind of representing a hidden knowledge that we should be encouraged to explore, to understand our human history through the arts. And I think as we do that, as we look at visual art, sculpture, dance, as we read good literature, what have you, in order to grasp what's in there, what's behind the human experience, we need to strengthen our senses. We need to really charge our imagination. And I think as a result, we start to think in a very creative way. We become aware and we learn to anticipate. And by doing so, we will deepen our consciousness of the human condition. And I think these are very, very important things to do as you become a physician. Because after all, you are going to deal with human life. You're going to be a healer and a helper. I would like to tell you that my husband fought carcinoid cancer for 12 years. And I don't think many weeks would go by without Stewart telling me how important it is when you are ill, that you have a physician that can kind of hold your hand, a person that you can trust, a human being with knowledge of other human beings that will help you, will guide you, will understand what he or she can ask from you, and be perfectly honest what he or she can give you. As Stewart's life progressed, and it became very, very clear that science no longer could help him, what's really helped him was this human warmth and moral support. The importance of that is nondescript. So, thank you.
Thank you very, very much, Ms. Reuter. It really is a pleasure that you could join us this evening, and to hear those words. I'm glad I don't have to speak too much after you, frankly. The Reuter Endowment, supporting tonight's event, is but one of their many legacies. Both Dr. and Ms. Reuter were early and are continuing supporters of our Center for Medical Humanities and Ethics and our Department of Radiology. I would also like to thank our other co-sponsors for the event this evening, the Center for Medical Humanities and Ethics and the Department of Radiology here at UTHSC, the San Antonio Health Literacy Initiative, the Patient Institute, and the Bexar County Medical Society. Thank you all. A little bit of administration here. For those of you seeking CME and ethics credit, please make sure that you sign in. There are two forms. There's one form where you need to write your name and email legibly. That's not easy for me, but hopefully you can do it. Turn it back in to the desk up there. There is a second sheet which tells you how to obtain the CME credit. It takes typically 2 to 4 weeks, but it will show up on the website, which is on the sheet, cme.uthsc.edu. It is now my pleasure to introduce Dr. Michael Paasche-Orlow. Dr. Paasche-Orlow is Associate Professor of Medicine at Boston University School of Medicine. He's a general internist and a nationally recognized expert in the field of health literacy. Dr. Paasche-Orlow is currently a co-investigator with 5 funded grants that examine health literacy. He is a member of the Project RED research team, a nationally recognized model to re-engineer the process of hospital discharge to improve the safety and efficiency of transitions of care. His work has brought attention to the role that health literacy plays in racial and ethnic disparities, self-care for patients with chronic diseases, end-of-life decision-making, and the ethics of research with human subjects. He is the Associate Program Director for the Boston University School of Medicine, General Internal Medicine Academic postdoctoral fellowship program. In addition to his presentation this evening, he will be providing the keynote address at the San Antonio Health Literacy Initiative annual Texas Health Literacy Conference to be held tomorrow at the La Quinta here in the Medical Center. And I encourage all of you to attend either all or part of the conference as you can break free. Welcome, Dr. Paasche-Orlow.
Thank you very much. It's really very much an honor for me to be here and to talk with you today about these topics. I hope by the end you can see that there's really a very good synergy between health literacy and the work of Dr. Reuter and his life. And I want to start just with the following. I did not know Dr. Reuter, but I really have enjoyed reading things about him, and thank you for that comments about him. Really, I found it very moving. My impression, and people who knew him hopefully will agree, that he really lived at the nexus of innovation and excellence, embolization and ethics, contrast agents and consent, angiography and art. And my charge this evening is to challenge everybody, challenge all of us to be inspired by his example, that we can also bring excellence to our work. And I hope in particular ways relating to some of the themes that I bring up. But you have to find whatever motivates you and just bring excellence to that. So the first thing, you get a little bit of privilege, a little bit of license if you're told to talk about humanities, because that means a lot of things to a lot of people. And so I want you to look at this picture of Dr. Reuter's and think of where you are on this picture. If you're a clinician, where are you? The whole milieu of all the forms and all the time pressures, the different contracts, all the patients that come and go, all those things. Where are you? Are you on this picture? Who are you in this image? Do you aspire to be a clinician of some kind? Imagine yourself here. And then think, where's the patient? Where's the patient in this image? And I think really from your comments, you have to find the patient. That's our job. We have to find the patient. One way to talk about this topic is the following. Join with me. I went to college. You went to college? My partner went to college. My parents went to college. Okay, not everybody. My grandparents went to college. All four of my grandfathers and grandmothers all went to college. My wife went to college, her siblings went to college, her parents went to college, and her grandparents went to college. This is a tremendous amount of educational privilege. What we have in this room is a tremendous amount of educational privilege. One thing you can say about this whole field of health literacy is the healthcare system has been created by people with tremendous amount of educational privilege, but often neglecting the people who don't have that. And so part of this message is to say, how will we remove literacy barriers from the system so we can actually create a system that people can use, that people can be empowered by? So let me back up. What is literacy anyway? Literacy is really a functional concept. It's not kind of an abstract thing. It's in a domain. We can legitimately talk about the literacy skills it takes to fix a car or to fix a computer. Some people say there's such a thing as fashion literacy. I don't have it. My wife tells me what to do. I try to do it. That's how it is. So there's many different kinds of literacy. Basically, it's all contextual. It depends on what you need to do. Now, there are some basic skills that make it easier. It's easier to fix a car if you know how to read, but there are plenty of people who do it without having those skills. It's easier to be a doctor or to do anything if you have those math skills, but there's a lot of things that people manage to do anyway. But those basic skills, reading, writing, arithmetic, they do make things a lot easier. But life is not kind of a reflection on what does this sonnet mean. That's like kind of a college view of literacy. Life is actually things you need to do. So there's no one literacy. It's all contextual. The demands are contextual. And in healthcare contexts, the question is, what are the challenges, what are the skills, what are the things that the person who's a patient that they need to be able to do? This is the definition, the official federal definition for health literacy. Maybe I can have a reader. Is this still on? Come on. This is the definition.
The degree to which individuals have the capacity to obtain, communicate, process, and understand basic health information and services needed to make appropriate health decisions.
Excellent. Thank you so much. I hate that definition. I don't like this definition, and I'm going to point out why. I'm going to point out why. There's some things I think that are distracting, inappropriate about this definition. Let me point it out. So one thing, I told you that it's contextual. So I don't think the concept of basic deserves to be here, because what's basic to you could be irrelevant to another person, could be absolutely critical to another person, right? If you're faced with the decision of, do I take chemotherapy for this drug, for this situation? If you're faced with this situation, I have a patient right now who has is offered coils to her brain, or wait it out. There's some numbers we can throw at them. We can say you have a 2.6% chance of it rupturing spontaneously each year for the next year of your life. And you could say, oh, but there's about a 5 to 8% chance that you're going to have a major event from this experience. That's completely irrelevant to most humans, but that's critical to that person, and they have to figure that out. And there's a lot to work through, that kind of a decision, right? So I would say, we're going to talk more about context, but what's basic to one person is just irrelevant to another person, is critical to another person. I don't think it deserves to be in the definition. Another thing is, it's not just information and services, it's also skills. There's a lot of skills in the healthcare context. If you have asthma, it's actually really, really, really good to know how to use an inhaler. And it's not like this. That's not an inhaler, right? I mean, it's very frequent. We say to patients, I want you to take 2 puffs every 4 hours, and if you actually look at what people do, it's like, that's not 2 puffs, right? So you need to actually see what people do, understand what they do, and figure out if they're doing it correctly. That's a skill, critical skill of health literacy for someone who has asthma, but may be irrelevant to a lot of other people. With diabetes, you need to know how that glucometer works. Who's going to teach the person how to use that glucometer? I mean, most of the time, the internist just says, blah, 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 check your sugars. How does that work? Who's actually going to teach that person how to use that machine? It's like mysteriously going to happen? No, it's actually something that people need to learn how to do. And don't be shocked that the person doesn't do it. If it's hard to do if you don't know how to do that. Many other kinds of skills are needed. So there's the next thing that I don't like about this definition is it focuses on the concept of appropriateness. Appropriate to whom? If I tell the patient, I want you to take this pill, and they say, look, it gives me a stomach ache. I don't want to take this pill. So do I rate them badly because they decide not to take it? Appropriate? No, who has the power to decide what's appropriate? The concept is not about appropriateness. The concept has to be about informed, empowered. It's not just, you must do what the doctor says. The concept of health literacy has to be about informed decisions and actions. Next issue. It inordinately focuses on the individuals. And until now, you might have thought this whole field is someone having a problem with reading or someone having a problem with math or something like that. But that's blaming the victim. That's blaming the victim. If I say it's contextual, if I tell you that health literacy has to be considered in a contextual way, then you also should say it's not just someone's skill level, but it's also Why do we have an inordinate amount of jargon? Why do we have clinicians who have very little training in how to communicate with patients? So there's a lot of things in here, and there's a lot of things that relate to this. You know, if you're doing procedures, you're involved with consent all the time. I know this was an interest that I shared with Dr. Reuter, and this is actually complicated stuff, and it's very easy to do this poorly, and people don't understand what they're getting themselves into. Very easy, very easy. You know, we're enrolling millions of people into insurance. That doesn't mean that people know what that means or how to use it. There's actually a lot of challenges. There's a lot of challenges. And there's too much information. It's actually very hard to be a patient. There's never enough time. We ask people to do very complicated tasks when they're not at their best. They're sick and they're in pain, you know, and now I want them to calculate their 10-year odds of having a spontaneous rupture of their aneurysm, and they're just, you know, it's scary, and they're sick, and it's not very easy. And there's more and more burden on patients. There's direct-to-consumer advertising, right? So we have all these ads on TV. People come in to me all the time, and they say, can I have that side effect? Can I have that side effect, please? Okay, come on. I got a few laughs, but I know all of you know what I'm talking about. And anyway, so there's also direct-to-consumer genetic testing. I mean, when I talk to patients about genetic issues, it is really astonishing how big a gap there is in comprehension. And participatory decision-making, this is something that's very challenging, too. I think it is a hallmark of progress that we've pushed away paternalism as the dominant mode of how we interact with patients. But make no mistake, it's a big challenge. You know, if I say to a patient, I want to talk with you about whether or not having a prostate blood test, having a PSA, I want to talk to you about whether or not this is a good decision for you, right? And at the end of a conversation about false positives, false negatives, biopsies, and this and that, they're like, I mean, you went to medical school. Should I have this? I don't know if you know if I should have that test or not. And, you know, that's fine, too. You know, sometimes people say to me, did you have that prostate test? And then, you know, that's a kind of a slightly different conversation, and you can decide if you want to go there. But if the same person asks my colleague Jane if she had that PSA, they do not understand what's going on. Okay, so you got to figure out what people understand. Now, in health literacy, there's a lot of different concepts. There are some basic literacy skills, like, you know, being able to read stuff, but there's also a lot of self-care things that are very specific to healthcare, and also very specific to healthcare in the United States. You know, the pill bottle looks this way in the United States. It does not look that way in the rest of the world. In fact, there's many different ways people all over the world get prescription medications. Is it a surprise that at the bottom it says, you know, refills, and then people come in, they don't understand what that is? That's actually not how it's done in many, many countries. It happens to me all the time that I say to people, how are you doing with that metformin? And they're like, I'm fine, I finished it. That's not diabetes care. That's not legit. That's not what we're talking about. And by the way, patients frequently have no idea that they're on the metformin, and the radiologists want to know that they're not taking it for 3 days or whatever. That's just, first convince the other clinicians that that's important to them. Now convince the patients that they even know what you're talking about. It's a lot of challenges. Anyway, I'm going to move along. So how common is this issue, low health literacy? How common is this? I want you to, some people have pens. Actually, I'm going to not call on you, I promise, but I do want you to write some things down, just to commit mentally on what this is. So how common is this thing, low health literacy? Well, you should say to me first, well, how are you defining it? How is it being measured? So what I'm going to give you is data for now. I could give you data from other surveys as well, but data for now is going to come from the NAL, which was done in 2003. I have plenty of other data too, but this is about 20,000 households visited and people tested, adults tested. And in this survey, they broke people up into 4 categories: below basic, basic, intermediate, and proficient. If you had below basic literacy skills on this test, I'll give you an example. If someone said to you, here's a bottle, and the bottle says, take 2 pills 3 times a day, and the task is, how many pills do you need to take out of this bottle for 1 day's worth of medicine? If you're in below basic, you typically would not get that question correct. Okay? That's just a framing of like what we're talking about here. If you're in basic, you typically would get that correct, but not questions that were harder. Okay? So this is the United States of America. So if you have a piece of paper, I won't call on you, just write down, what do you think that's going to look like if I break this up by race and ethnicity? And this is one of those messages that I think is very, very important that I want you to focus on from this conversation, because I think this health literacy conversation will end up being a key to ameliorating disparities in the United States. Okay, so on the next slide, it's going to be the same data broken by race and ethnicity. Ready? Will you write something down? Okay, you saw here all adults, 14% and below basic, 22% in basic, right? So you do not need higher math to look and see that this is a dramatic phenomenon. This is a very, very big phenomenon. But dig deeper. By income, how far you stay in school, okay? Stay in school. Okay? The next couple of slides, I'm going to give you data from another source. This is from the National Assessment of Childhood Competencies. This is tests done on kids in 12th grade in high school. Okay? This is another source. This is from the NAEP. There's supposed to be another round of data coming out soon. It's not available yet. 2015 data. Fine. Reading. The next slide's going to be for math. Is it going to be better or worse? Okay. Now, when you look at something like this, you have to really try to focus what this means in healthcare. Okay? What this means in healthcare, I gave you an example of 2.6% chance of aneurysm rupture each year for the next 10 years. What are you talking about? Patients frequently do not understand this, okay? I did a study where one of the questions was, what's the likelihood that you're going to develop cancer in the next 5 years? And then we asked people, what's the likelihood that you're going to develop cancer in the rest of your life? Okay? No matter what numbers you give, if you think your lifetime likelihood is higher than your 5-year likelihood, you don't understand the question, right? I also asked them, fair two-sided coin. You flip it 1,000 times. What's the most likely number of times that it's going to come up heads? Now, there's only one right answer. If you say, I think it's going to be 477, it's not the right answer. 40% of the patients at my hospital got one or both of those things wrong, either the coin flip or the prevalence concept. 40%. And so what patients get, what patients understand from us is not the numbers. They understand our affect. They interact with us and they see, this person seems like they care, or not. This person seems like they're a good person, or not. Largely speaking, our interactions are not happening through a cognitive lens. Largely speaking, when you're talking about this kind of a phenomenon, they're happening through an affective lens. And so you have to think about, what is the affect that I'm giving off? And what does that mean? And am I being appropriately empathic in this scenario? Am I being trustworthy? And you mentioned empathy, and somebody else mentioned empathy before. And I did a study once where we listened to over 600 outpatient encounters between doctors and their patients, and we listened to audio tapes. And one of the things we did was listen for jargon and stuff like this, but we also listened for empathic statements. How frequently do internists and family medicine doctors make an empathic statement? Any guesses? So it turns out in our study, there was one empathic statement for every 3 to 4 visits. And this was a study where we uploaded, we had a high selection for people with high CSD-9 scores, so there's a lot of depression and anxiety in the patients. Basically, what it means is that doctors are kind of mean to the patients, kind of mean. Literally, you can listen to statements that like people taking a family history. It's like, oh, tell me, is your father alive? Any medical problems? Oh, he died. Yeah, your mother? You wouldn't talk to that. You wouldn't talk to a person like that. You would not talk to a person like this. And doctors talk like this all the time. Where did they learn that? They were not like that when they went to medical school. Okay. Now, I just want to point out that there's been fabulous improvement in this. Having a high school diploma or a GED has been massively improving in the United States from 1980 to 2011. Big improvements, but still massive disparities. And then the quality of the education, that's a whole conversation to be had. But I'm going to move on because I want to focus on other things. I did some other things showing that this is like very, very common in the health industry. Okay, fine. So why does this matter? I want to focus a bit on why does it matter that there's these loads of people, 30% more, 90 million Americans with low health literacy. Well, it turns out that there are many, many examples where this literature that's emerged, called the literature on health literacy, has shown that having low health literacy is linked to all kinds of bad things. All kinds of bad things. I'm just going to go to one example, which is the example of mortality, the final common denominator. And really, we could spend a couple of days just going through all this literature, because there's a lot there. Now, in this study, this was elders. They were 66 years old to get into this study. It's about 3,000 people. And you can see they were observed over time. And the hazard ratio, this is well controlled. This is controlled for blood pressure, controlled for smoking, controlled for Charleston, it is controlled for diabetes. Like, this is amazing that you would have a hazard ratio of 1.52 over the course of 80 months for death. That's like adding a whole chronic disease to a population and say, carry this around. Okay? So the question is going to be, what would be the connection? What possibly would be the link for someone who's 66 that they would die more likely over the next 5 years? What's the causal pathway? How is it going to work that low health literacy would link to all these bad things? And what's recommended these studies is that people have tried to control for important confounders. You never do it perfectly, but they've tried, okay? And so here's my simplified conceptual model. Thank you very much. I got a good chortle in that one. Okay. And besides the fact that, you can learn how to do things with PowerPoint, I'm going to try to focus on a few things here. I want to set aside some very important things. If your barrier is neurosensory, if you have a problem with vision, the intervention is quite different. And so I want to set that aside. Just by the way, what's the leading cause in the United States of America, the leading cause of having vision so bad that you cannot read? The leading cause? I heard diabetes. What else? Hypertension. MAC-Degen. Anything else? Glaucoma. The leading cause in the United States of America, strongest economy in the world, is refraction. Needing glasses. In every state in the United States, if you are functionally blind, the glasses can be paid for. The doctor has to say that you are blind because of this, and then you won't have to pay, Now, what's the second leading cause in the United States? Is cataracts. In every state, you can have your cataracts paid for if you're functionally blind because of your cataracts. Now, I love cataract surgery. It usually works so well. It's like one of the things that I love to send people for. They come back really with the life improvement. But it's a little more complicated than this. If I couldn't see, I would be running. I need to be reading all the time. I have so much of my world is text. So there is an overlap between people who have not gotten their glasses, have not gotten their eyes fixed, and higher rates of low literacy. So you have to think about, why is it that this person still 3 years into whatever the issue is hasn't gotten their eyes? But there's a lot of barriers, and there's a lot of perceived barriers that are not even real. So we have to figure out how to help our patients. So let's set aside these things. If your barrier is memory, the intervention is different. Okay? Let's just set this aside. Now, there's other things to set aside too. And there's also interesting and sometimes very, very interesting and important interactions. If the challenge is language, there should be language-appropriate services. And this is a whole conversation of how and why and when and where. Why do we fail so frequently about having language-appropriate services? This is a huge topic that I think is going to be, that's really underplayed. But let me set that aside, and we'll talk. Maybe we'll get a chance to talk about that more. All that goes away. Oh, it's a shame. Okay, so what I want you to see is there's 3 big boxes over here, and in each of these boxes there's 2 sections. So the first big section is called access and utilization of care. So there you go. And what I want to impress upon you is I think it's very important that in each domain, don't just blame patients. Also think of the system and how it's constructed to be a support or not. So why is it so difficult to apply for Medicaid? Why is it so difficult to get the benefits that you're eligible for? Well, there's different reasons why, but the forms are really complicated. Most people are not even able to fill them out themselves. They're filled out by the health system, so they'll be reimbursed after an acute episode. So like that's not using the systems appropriately. That's not using it for prevention. That's not using it for anything that you would look at that and say, oh, that's a good use of our healthcare system. That's using it for paying back the hospital afterwards, after you had an acute event that should have been avoided in any way. So you can't just say, oh, patients have poor navigation skills. Why is it so complicated to get through the system? The next kind of domain, and I don't want to get too deep into each of these, but just at a high level, is how patients interact with providers. So when you read literature that talks about patient self-efficacy or empowerment, fine. But at the same time say, well, what is the efficacy of those clinicians? What is the empowerment of those clinicians to be able to talk about those things effectively? We frequently talk about knowledge, attitudes, beliefs. Yes, that's true about the clinicians as well. Just don't focus too much on the patients. They deserve focus, so does the system. And then a lot of care is self-care. It's very hard to remember when you're in residency, because so much of the residency happens in the hospital. But the vast majority of those patients' lives are not with us here in the hospital. The vast majority of their lives is at home, when taking care of themselves, hopefully, and hopefully doing a good job, but we don't make it very easy. There are over 60,000 health apps, but they're not really used. They're not very effective. They're made for the digerati. And even us, even when I bet we go around and look at your health apps, you probably touch them 4 times and don't. Look, my heroin addicts are not using Fitbits. Okay? Whatever you want to say. I could probably go around and find a few Fitbits on you all. But, it's probably not meeting the target of the need. I don't have a single patient with an A1C over 10, 12 that's interested in Fitbit. Okay? Okay, let me go on. So I want to now point out some other themes that I think are critical in this conversation. Another reader.
Someday you'll act like you understand.
Yeah, we do this thing in healthcare. We shame people. We shame people into silence. It's astonishing. It happens in all the different ways that are very difficult to get by. Some doctor at some point in someone's life was walking out of the patient's room saying, "Any questions?" leaving the room. And that will make a barrier to all of the other people who come in the white-coated time-space continuum in the rest of their lives. You have to fight against that to be able to overcome that. There's so many examples of this. I had a patient, I think MedRec includes minimizing out-of-pocket expenses. That's a whole other conversation. So I had a patient where I said to him, "Hey, what did you have to pay for these medicines?" And he said, "Oh, I'm glad that you brought this up because I couldn't get the medicine." They wanted like $250. And I was surprised because I didn't think it would cost him that much. So while he was there, we called the pharmacist and we figured it out. It was like $15 because we have a very, very well-supported system in Massachusetts. Anyway, so I said to him, where did that number $250, where did that come from? $258. Where did that come from? He said, it turns out that 3 years before, he had been discharged from a hospital. He went to the window. Some resident had ordered an antibiotic that was not covered by his plan. He was asked for $258. He left in shame. He had not gotten any medicine for 3 years. He'd been my patient in the clinic, A1C through the roof. How are you doing with your medicines? Fine. Okay? So we shame people in all kinds of ways. Everyone, there's all kinds of shames that we do. Some of it is about literacy. Some of it is about money. All kinds of shames that we shame people. We have to find our way past that. Everybody has questions. Everybody has questions. If you do not get to the questions, you have not done your job. We'll talk about that a little more. What is this? You have to give it to somebody else. What is this? What is that? Where is that?
I have no idea.
Okay, give it to somebody else.
Is that Los Angeles?
That's LA. That's LA. There you go. What's the point of this picture? The point of this picture is to say health literacy frequently travels with other vulnerabilities. I told you that what recommends the research literature is that we've looked to control for the effects of other phenomena, to identify and isolate the independent phenomenon of health literacy. But human beings are not regression analyses. You want to do something in the world, you have to find people where they are. You can't say, oh, I'm going to intervene on this part of you, stand like this, and then it'll work. No, you have to find people where they are and understand the nature of their other vulnerabilities as well. You can't pretend like there's no language access barrier, right? You can't just say, because you have the interpreter there, which is great, that doesn't mean that there's no health literacy barrier in the other language. So you have to figure out all the collective vulnerabilities and figure out how to manage that. I'm going to give you another, this is a complicated slide. Okay. This is from the M.P.H. Over 160,000 people surveyed in all these different countries. The United States is all the way at the bottom. Okay, that's not good, and let me explain what this means. You get a blue diamond, a blue arrow top. That's your average literacy score if both of your parents went to school past high school. Both of your parents had at least some college. And that's what you got. You get the blue arrows, right? If one of your parents went past high school, there's the white diamonds. And if neither of your parents went past high school, those are these black checks, right? What this means is, in the United States, we have an educational caste system. We have the lowest level of social mobility for educational achievement of any of the countries in this system. This is not our self-perception. This is not how we think of ourselves. We think of ourselves as a land of opportunity. Yes, but if you look at this, you have to say, in comparison to any of these other countries, this factor is more important here than other places. It's true in every country that your educational attainment is massively influenced by your parents. You will find people who will break away from that. You will find people who are the first people who go to college in their family. That's awesome. They are awesome people. And then you can empower other people to do it too. But overall, this is a yoke that we wear in this country. This is connected to the fact that we pay for our school districts in part by local property taxes. This is part of how we have massive disparities between different school districts. If you just think about what this means, why would it be that in all these other places you have more social mobility for education? It's connected to the overwhelming cost of education. All right, that was my soapbox. Let me go on to the setting. Now, if you want to go into clinical care, I think there's some very important messages that can come out of this. One thing is I call universal precautions. I do not recommend screening people for low health literacy. I don't think it's useful. I think instead we should flip the default. Instead of waiting for the patient to say, hey, I don't understand that, I think you should say, it's my responsibility to confirm that the person understands. If you have something critical that you need someone to know, then you have to figure out that they know it. Where'd the mic go? All right. If you go into like a McDonald's or something, and you say, I want fries and a Coke, what do they say to you?
Oh yeah, they ask if you would like to
Super
upgrade.
size.
Yes,
Super size.
size.
Okay, after they try to increase the sale, what do they say after that?
They say that it would cost less if you.
Oh, well, they try to do that too.
Okay.
That's like a strong. They try to sell more, but at some point, they confirm the order. They say that would be fries and a Coke. Okay? They do this for a number of reasons, but essentially because they understand that it's a service economy, and you're going to be unsatisfied if they don't get the order right. Okay? When I was a kid, my parents just made it clear that I was going to be a doctor. It was actually very unsubtle. They would say, oh, the world is your oyster. You can do anything you want. You can be a cardiologist. You can be a pulmonologist. You can be anything you want. But they had this idea that being a doctor was like being a doctor was something. But I'm telling you now, this is part of the service economy. You actually have to do the job right. If you want to do the job right, and part of our hospitals are now already being scored on satisfaction. That is actually already being built in. The idea that patient satisfaction would be related to compensation is astonishing, but it means that you have to do the job right, and you have to figure out how to do the job right. And if you want to do it right, you have to confirm the order. If you have something critical that you want the patient to do, check on it. I asked you to take, when we're talking about taking this medicine, you said you were going to do it. Great. Tell me, how are you going to take this medicine? Tell me, how are you going to do it? Confirm the comprehension. The next thing is I think we need to systematically reduce unnecessary complexity and massively increase resources for patient education. The whole concept of the medical home, whole nother conversation, but it needs to be a home of education, patient education and empowerment. So I say to people, I don't say to people anymore, I try my best not to say, how are you doing with the medicines? Because if you say, everything's okay with the medicines, you will not get any, it's like ships passing in the night. You will not get any information. If you say to people, you did that bowel prep? You have no idea until you go in, okay? Then you know that it didn't happen. I'm not a GI guy, whatever. So you have to find it. So I say to patients, when I talk to patients, they say their A1C is over 12 or whatever, I say, are you satisfied with your care with diabetes? Now, if they say yes, something's really wrong. If they say yes, I'm pulling out all the stops. I'm going for the guilt. I'm going for anything. I was like, look, you're satisfied? I'm going to go home worrying about you. Use anything you can, right? You're satisfied, but I think, this is actually really not good for you. This is the way towards losing your kidneys, losing your erection. That gets it started. You have to find the person where they are, and you have to figure out what the message will be that will connect with them. Leading cause. Okay, wait a minute. So I told you, I asked people, how much does it cost? Follow the money. People are ashamed about this, but you have to be able to do it. You have to be able to do it comfortably. If you can't ask about this, you're just fooling yourself. You're pretending like that doesn't matter, or it's not a barrier in people's lives. Of course it's a barrier in people's lives. And the thing is, if you say to a patient, when you went to the window, how much did you have to pay for this medicine? If they cannot answer this question, they did not get the medicine. If you took the money out of your pocket and you paid for it, you know the answer to this question. Okay, it doesn't work every time. Maybe the niece got the medicine. Okay, it doesn't work every time, but it works great. It works so much better than many other things we try to do. You have to find ways to communicate with patients at work. At every single encounter, every time you're working with a patient, you have to figure out what is the critical thing I need them to understand and figure out how to confirm their comprehension. You have to do it in a way that's not loaded with jargon. It's not funny. It's not funny. The jargon is a very dangerous thing. And it's very hard to find your own jargon. Let's play a game, okay? I'm going to say, Anjana, you say? Okay, I'm going to say benign. You say? It's not cancer. Stop saying benign. That's not good. You know, it came out benign. Well, is that good or bad? Immunization. Okay, how about this one? Hypertension. You have the hypertension. Okay, you still have to talk to the person to understand what they think that means. The whole chronic disease concept, there's a lot of misunderstanding. It's like, well, it happens when I'm yelling at my kids and I have a headache. There's a lot of misunderstanding. Your test is negative. Diet, it's just a 4-letter, 1-syllable word, but it means something special in a healthcare context. If you say to a patient, if you say to most people, humans, how are you doing with your diet? I'm on a diet. I said to a guy recently, we talked about, changing how you eat. His A1C is through the roof. I talked about A1C, he said, oh, I'm doing exactly what you said. I'm not having carbs anymore. I said, really? What did you have for dinner last night? And he said, oh, no carbs. I said, fine, what did you have? He said, oh, I took a pound of butter, I put it in the pan, a pound of ground meat, and a pound of calamari. I used to eat that on a pound of spaghetti. We're not done. We're not done. You have to find your jargon. I said to a patient once, we talked about not eating red meat anymore. How's that going for you? He said, no problem. I cook it all the way through. Okay, you have to find your patient. You have to find your jargon. You have to find your jargon. I've done a lot of research about how patients are discharged from hospitals. We've done all kinds of things, focus groups and different things. 3 focus groups into one project where we're showing them new information and stuff like that. There's a guy in the back of the room, he said, oh, this is good. I like this project. This is good. But I'm confused. What part of the body is the discharge coming from? You have to talk to patients. So we call it the after-hospital care plan. You have to talk to patients and figure out what's going on. So I'm not going to spend so much time on this, but this is a model I want everyone to learn about. This is called closing the loop. You have a new concept. You want to confirm that the patient understands it. You say to the person, tell me how you're going to do this. For example, I want to make sure I explained everything clearly. It's on you. You're supposed to be the communicator to teach in this. I want to make sure I explain things clearly. Tell me how you're going to, show me how you're going to use this inhaler. Now? Yeah, right now. Show me how you're going to use this inhaler. And then you can give them feedback about the things that they got right or didn't get right. You can focus the feedback on the things that they didn't get right. And then you have to close the loop. You show them, say it again. Show me now that you get it right. So here's an example. Where's the mic? You have to pass it to somebody else. Okay, there's a reading moment. Okay, so there's a lot that's coming up. There's a lot of things that are very complicated in healthcare. One example is public health. I mean, is vitamin E good for you or bad for you? Okay, so the messages are too complex. We have to complete with sex, drugs, and rock and roll. We're pushing like metformin, and they have like all this other stuff. Like, how are we going to compete with Snickers bars? Okay, we have to do a better job, but it's going to take work. The information changes. It's complicated stuff. It's massively, just grossly insufficiently targeted. That's a whole other conversation. There's all kinds of issues that we're not dealing with yet about language and literacy and culture and context. So here's this. Can you read this one for me? Read it.
The nation needs AIDS, free men and women. Let's protect ourselves.
Okay, so if you're driving down the highway, okay, so anyone else want to read it? Hand it to somebody else. Read that. See, do you want to try another reading, a different reading maybe? Try it again. Just read it.
The nation needs AIDS, free.
So what I want to point out, like, anybody get it? Anybody want to read it differently? The nation needs AIDS-free. See the little hyphen over here? The nation needs AIDS-free men and women, let's protect. So there's a lot of ways you can go wrong. It's very easy to screw this up. So I want to move on to the next part of the talk, which is that I think that hopefully that I've shown you that health literacy can work towards, can influence health outcomes. I just showed you a slide with a lot of things on it, but hopefully you believe me. And then hopefully I showed you that there's massive racial and ethnic disparities in health literacy and literacy. But the question then is, how would it be that differences in health literacy would end up causing health disparities, in racial and ethnic health disparities? I'm going to give you a few examples. So here's an example from a medication adherence project I was involved with. This is a small cohort of people with HIV, 204 patients with HIV, and we noticed, and there was a paper written saying that there was lower medication adherence among the African American patients in this cohort. And okay, you say, okay, I want to do something about that. But I would say, wait a second, look at the data. So what happened was, in the analysis, when you did not look at health literacy, African Americans were 2.4 times more likely to not be adherent. But if you included health literacy, there was no race effect. It wasn't a racial phenomenon. It was a health literacy phenomenon. In the final model, when you controlled for health literacy, the health literacy was the only significant independent predictor. So what does this mean? That means if you want to do something about this problem, you have to consider this factor. Health literacy barriers. It means that if you started creating an intervention that was about, say, cultural competent care, you'd probably be barking up the wrong tree. Here's another example. This has to do with end-of-life decision-making. I've done a suite of studies in this space, a couple dozen studies in end-of-life decision-making. And there's a literature that purports that African Americans want more aggressive care at the end of life. And I always said to myself, really? I mean, how were these studies done? Are they done appropriately? Do they explain things appropriately? Is it, and do they test for literacy and use that in their analyses? So what we did was, in this particular study, we have done others as well, we asked people about their end-of-life preferences before and after a video, an educational video. And in unadjusted analyses, African Americans wanted much more likely to have aggressive care, an odds ratio of 4.8. That's very strong. More aggressive care wanted. In unadjusted analysis, but in an adjusted analysis, when you put the health literacy into the model, the race effect went away. It wasn't there. In unadjusted analysis, the health literacy effect was massive, and in final adjusted analysis, that was the main dominant independent predictor for wanting more aggressive care. By the way, after the video, there were no racial differences, and there were no health literacy differences. So, that means that we cannot skimp on the educational agenda. We have to engage people to make sure they understand what we're talking about. If you think it's going to be like on TV, where some beautiful person comes and does like this on your chest, and then everyone's smiling by the end of the 30-minute episode, you do not understand how the hospital actually works. That's not how the hospital works. There are very important themes here. There is a very important underdeveloped theme in culturally competent care, but that can't be in contest with our educational agenda. We have to have both, and we can't have both. I'd like to give one more example, a paper that I read just this morning, which had to do with radiology. There's so many radiologists in the room, I thought, I was actually told, have a radiology example. Okay. This is just an example. This is not in the radiology department, but it's tests ordered for radiologists. So this was 504 caregivers of children. And in this hospital, the black children were much less likely to get any radiologic testing in the emergency room after controlling for various things. And it turned out that actually when you control for literacy of the parents, that this was not a phenomenon of the blackness, it was a phenomenon of their health literacy. So there was an interaction. So this effect of not ordering tests for kids was really a phenomenon of the kids with the parents who had low health literacy. This is parental health literacy in this scenario. So I don't want to go too far into this. I want to just give you some examples of some of the work we've been doing at Boston Medical Center to try to ameliorate these issues. we have done a series of projects now with an animated character that we call embodied conversational agents. Here's one example of our animated character. This is a character that we used to teach people about, about things they need to learn when they're discharging from a hospital, about their medications and follow-up appointments and things like that. And the character interacts with patients in ways that, it's software. You can make it do whatever you want, right? So it can be as much social talk as you want. It can have as much empathic comments as you want. And it can adapt based on what patients want. So if patients start asking questions and are more interested in empathic issues, then it can go there farther. And it's in ways that clinicians tend not to do. If you listen to clinicians, even when empathic topics come up, they shut them down. When spiritual topics come up, they shut them down. But the character doesn't have to be like that. It's just software. So I'll give you an example. I prefer Louise. She's better than a doctor. She explains more, and the doctors are always in a hurry. We train people to think patients to think that our time is precious and their time is nothing. We train them that way. So the idea that sitting with an animated computer character could be satisfying is really a bad reflection on our culture, in my view. And yet, I think it can help. It was just like a nurse, actually better, because sometimes a nurse just gives you the paper and says, here you go, and Louise explains everything. Here's another example. We did another study where this was a character to promote walking in the elderly. People said to us, you cannot give a computer to old poor people in Boston. The computers are going to be lost, stolen, or broken. They don't know how to use computers. Well, we did this trial. Not a single computer was lost, stolen, or broken. You can make an interface that will work. The average person in this study was a 74-year-old African-American woman who had never touched a computer in her life. Okay? You can make it work. Here's an example, like the character talks and then the user responds back with a touch screen. In this study, this was like all of 5 years ago. So if you remember, there was like no Bluetooth pedometers back then. Now, like everybody in the room has a pedometer in their pocket. But back then, in order to make this work, we had to have an actual pedometer. And then in order for it to talk with the character, we actually needed a cable. It's insane, but that's what we did. And then the character would know how much steps you had. And so the character could talk with you about that, help you set goals. And what happened was people walked more. We took them away at 2 months, and the effect waned by 12 months, so it wasn't like a home run. But I tell you, the average user interacted and had what we regarded as a full interaction 31 out of 60 days. So you try to do a behavioral intervention where people do your behavioral intervention half the days. It's actually quite optimistic. It means you can do these things, you can make interfaces that people will respond to. It turns out that some of these topics, the empathy, the social talk, are much more embraced by people with depression and people with low literacy. And we give people surveys like how satisfied you are, all kinds of things. But we also ask them questions like, do you like Tanya? Or in this character was Tanya. Or do you feel that she trusts you? Okay? It's a computer. On a Likert scale between 1 and 7, the only answer is 4. You cannot give me any other answer. Does she trust you? But nobody gives us 4s. Everybody rates it highly. And that means that people are willing and open to having these kinds of engagements, right? The only answer is 4 all the way across. The character does not have any emotions for you. It's a computer. But people get into the conversations, get into the whole concept of it. So I'm going to end with this, and I want to ask what questions you have for me. If I don't generate questions, then I'm going to tell you other obnoxious things.
Could you kind of speak to how the culture of, kind of disconnect from the patient and the provider, some of the factors that have brought I can expect an experience with a provider to be kind of didactic or cut off. Could you speak to some of those factors?
I don't know, there are different ways of being a clinician. I find it more satisfying life in clinical care when when I can elicit the person to be there in the room, and that I can also be there in the room. Now, it's not my sob story, but if I don't make my patients cry, I'm not getting to the truth. In fact, I would say that on an average clinic day, if I touch my stethoscope more than make a person reach for a Kleenex, I'm not getting to the truth. The stethoscope is mostly a totem of our power. I mean, it's useful now and again. I don't want to disparage it too much, but ostensibly, that's placed there to say I'm the boss. Set it aside and get to the Kleenex, and then you'll get to more of the facts of the matter.
Oh, we'll come up.
You said that clinicians tend to shut down the conversation when spirituality comes up or emotions come up. What do you attribute that to? Do you think it's just like a lack of patience, or do you think that, sometimes, we don't want to influence or share of ourselves, or even try to, some people are even scared, like, if you say the wrong thing, a patient, it could even lead to a lawsuit, maybe, you never know. But what do you attribute that to?
Well, I do think that there's I think there's a phenomenon in the culture to not want to go there for a lot of people. I'm not advocating for the clinicians to start talking about their spiritual journey and this and that, That's not what I'm talking about. But we have a new grant, we're not in the field yet, we're still designing this, where we have an animated character for patients with advanced illnesses. And the idea is to try to identify unmet palliative care needs. And so we've had some pilot work already, and patients actually are very happy to talk with the character about their spiritual needs. I think that what happens is, for many, many things, patients send signals that they're hoping to talk about one thing or another. It could be many types of things that they feel stigma about. Patients will send you a signal that they want to talk about addiction. Are you ready to hear it? Are you open to talking about it? Patients will send you a signal that they're dealing with depression or anxiety. You have to be open. You have to be able to see it. You have to be able to appreciate what's there, and you have to be able to engage people with that. And people do the same thing about spiritual needs too. I think I'm kind of like a lightning bolt for this, because I'm willing to have people talk with me about these topics. But I think those messages are there all the time, and it's just a matter of if you're open to that. Now, I think that we have to be very careful, though. The clinicians are also incredibly pressed for time. And so the question is how to do this well and not neglect your other patients and be able to maintain a system. So we have to make space for some of these things. And there's a lot of challenges. Clinicians are under a lot of pressure. I don't want to get people like I'm in a bashing spot about that. But people are also shutting the patients down. And so we have to figure out how to connect to people, how to let them express themselves. I think we'll have a more satisfying life as a clinician. If you look at, there's a series of studies done by Deb Reuter out of Hopkins, where she looked at satisfaction after appointments by the clinicians and by the patients, right? And sometimes you see like the clinician was unhappy and the patient was unhappy. Sometimes you see that the clinician was happy and the patient was happy. But she's done some work where she's looked at when there's a disconnect, when the clinician is happy and the patient's unhappy, or vice versa. And there's several themes in there. One of the themes is low health literacy. The clinicians are like, quick visit, patient had no questions, awesome. Patient was like, I don't know what just happened, I don't know what I'm supposed to do, and what was that? So and there's other themes like that, and I would say that it's good to be attracted to situations where there is that disconnect, because then that can get you thinking about ways to improve care.
Thank you. So I think there are a lot of learners here. And, the AAMC, the American Association of Medical Colleges, they are encouraging all active learning and taking away all the learning from the professors and the teachers, thinking that active learning is better than passive learning.
Oh.
But in my experience, what all these things we are talking about, the students or the learners in general, nurses, doctors, physicians, physical therapists, they will learn a lot of these things which are not described in the textbooks. To describe how you actually show empathy to a patient, probably you have to write several articles, whereas you can show that to your student in one touch like this with a hand, or how I speak, what the tone of my voice. I learned a lot of things from my professors, and I think we are putting them at a disadvantage. Do you have any good ideas?
Well, I think that in general, there's a very important insight. Whatever the official curriculum is, there's also a very big unofficial curriculum. And so, I say do X, Y, or Z, but then if you go to the wards and you see something else, then you say, okay, well, this is how it really is. For many of these topics, I think that you can be your own critic of behavior that you see around you, and you can say, I'm going to try to do better. Or you could say, this was good, I'm going to pick up on this. I'll give you a good example. A couple years ago, I gave a speech about jargon in morning rounds. And then that morning, I was on rounds and I was walking into a patient's room, and one of the residents said to the patient, oh, we gave you something, but we'll see what the MICs show on your plates, and then we'll probably change the antibiotics. So I said, what's a plate? She looked at me like I was a complete idiot. She was like, a culture plate. That's what she said, a culture plate. I said, oh, what's culture? These are hard lessons to learn, plate is actually something you eat food off of. It's not like, it's very clear what a plate is to a patient. It's not a culture plate. There's no agar involved in most people's dinner, right? So you just have to think about, so we went back and I said, let's talk with this patient again. And let's see, what were you trying to say? And let's see if we can understand each other better. It's difficult, though. You really have to listen to yourself, and you have to figure out where are you going to be able to make improvements with comprehension. There's a lot of scenarios where really we're misunderstanding our power. I think a lot of this thing is about power too. When you go into a patient's room and you're going to talk about something difficult, sit down. Sit down. It'll affect how you talk. It'll affect how they talk. It'll affect how they listen. They'll notice that something is different. I'll tell you an example from when I was a sub-intern. I was a very, very eager sub-intern. I would come to the resident, the intern, say, I'm here, I'm going to take your admissions. I was very, very eager. And so one day I came in, I said, I want to take your next admission. And the intern stumbled out of a patient's room, and the patient's yelling at the intern, and the intern just says, I've had enough. And the resident said, that's your patient. So I walked into the room, I was like, hi, I'm your medical student, I'm going to be your doctor, blah, 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 blah. And the patient, very big impact on me. The patient said, shh, Coltrane. And I was like, what? So then I listened, and he had music playing. He was playing A Love Supreme by John Coltrane. It was the first time that I had ever seen a patient having their own music. I was in a very poor hospital at the time. I never saw that before. And for whatever reason, his way, his power to me, I just pulled up a chair and sat there. And I realized that nothing was to happen until it was ready, until he was ready. At one point, at the end of that song, I noticed that the tourniquet was still on his arm, and he was still dripping blood out of the poorly placed catheter. Just a little bit of blood was dripping out. And then I started thinking, it's dark in this room. He has the lights off. And then I said to him, you have a headache? He said, yes. And then he said, I've been losing a lot of weight. So you have to put this in context. This is Manhattan in the early 90s. So this is HIV. He had cryptococcal meningitis, and by sitting and talking with him, I could do the LP, I could get him treated. He did great. But without engaging with him, without sitting and talking with him, without listening to his music, it was going to be a fight. And he, so I think that some things are just, you have to just be able to do it somehow, be open to this somehow, find the patient somehow, and just demand of yourself, who is the patient that I'm with? Am I ready to be with this patient? I mentioned to somebody just in the hallway, I mentioned to someone in the hallway that we wash our hands. We go from one room to another, we wash our hands. What I would like you to do is when you wash your hands, of course you're going to wash your hands. Of course you have to do that. But when you wash your hands, I want you to say, I'm now dedicating myself to focus on the next patient that I'm going to see. Tune everything out. Get rid of all the other stuff. You wash your hands as a dedication to the next thing you're going to do. You're now going to sit with another person, another human being, and you have to focus on them. Not how many admissions you're getting, not your frustration with the other team members, or whatever it is. Just get rid of it, focus on the next patient. And that washing of your hands can be your dedication to that act. You have to wash your hands. Make it be a motivation for you for good. Thank you very much.
Thank you so much.
You're welcome.
We have lots of time.